Now let's review platelet aggregation. Platelet aggregation is necessary for platelets to stick together and form a platelet plug. In vivo, meaning inside the body, several agents can trigger platelet aggregation. These include ADP, collagen, epinephrine, thrombin, serotonin, arachidonic acid, ristocetin, snake venom, antigen antibody complexes, and fibrin degradation products. In vitro or in the laboratory, we use a smaller list of controlled agents to induce aggregation. These include ADP, collagen, ristocetin, epinephrine, thrombin, and arachidonic acid. How is aggregation measured? It is typically measured using photo-optic methods. As platelets aggregate, the turbidity or cloudiness of platelet-rich plasma decreases. Samples are kept at room temperature and then warmed to 37 degrees Celsius prior to testing. Stirring is required so that platelets come into contact and aggregation can occur. Aspirin has a specific effect. It inhibits the secondary wave of aggregation because it irreversibly blocks cyclooxygenase. Certain diseases show abnormal aggregation with Ristocetin. In Bernard-Soulier syndrome and in von Willebrand disease, Ristocetin-induced aggregation is defective. The bottom line, platelet aggregation is essential for hemostasis, can be triggered by many natural or laboratory agents, and is measured by optical methods. Aspirin and certain inherited disorders produce characteristic abnormalities that are important in diagnosis. This graph shows optical platelet aggregation measured by light transmission. On the left, we see the normal collagen aggregation curve. At first, there is a rapid drop in optical density. This is the primary wave of aggregation, caused by platelets sticking together in response to collagen and ADP release. After this, we see a second, stronger and sustained fall in optical density. This is the secondary wave of aggregation, which depends on thromboxane A2 generation from arachidonic acid metabolism. On the right, we see the effect of aspirin on the collagen curve. Here, the primary wave is present, but the secondary wave is absent. This happens because aspirin irreversibly blocks the enzyme cyclooxygenase, preventing the synthesis of thromboxane A2. Without thromboxane A2, platelets cannot sustain the secondary phase of aggregation. The bottom line? A normal curve shows both a primary and a secondary wave. With aspirin, the secondary wave is missing, demonstrating its effect on platelet function. Now let's review how to differentiate platelet disorders. First, Glanzmann's thrombocythemia. In this condition, the platelet count is normal and the morphology is normal. The key abnormality lies in the assays. There is abnormal aggregation with all agents because the glycoprotein 2B/3A complex is missing or defective. However, Ristocetin-induced aggregation is normal, since von Willebrand factor is unaffected. Next, Bernard-Soulier syndrome. Here, the platelet count is moderately decreased, and the platelets are characteristically giant in size. The key defect is in adhesion. Ristocetin-induced aggregation is abnormal, but von Willebrand factor is normal. This reflects the absence or dysfunction of glycoprotein IB, which is necessary for von Willebrand factor binding. Finally, von Willebrand's disease. The platelet count is usually normal, and morphology is normal as well. The problem again shows up in adhesion. Ristocetin-induced aggregation is abnormal, but unlike Bernard-Soulier, the von Willebrand factor itself is abnormal or deficient. The bottom line? In Glanzmann's, the problem is aggregation. In Bernard-Soulier, the problem is adhesion with giant platelets. In von Willebrand's disease, the problem is adhesion due to abnormal von Willebrand factor. Now let's review some specialized factor assays and hemostasis testing methods. Factor assays begin with PT and APTT testing performed using specific factor-deficient plasma. The percentage activity of the patient's plasma and the amount of correction with normal plasma are determined. A range of 40 to 150% is considered normal. The dilute Russell's Viper venom test, or DRVVT test, uses snake venom that directly activates factor 10 in the presence of reduced phospholipids. It is prolonged when the lupus anticoagulant is present. The anti-factor XA assay is used to monitor low molecular weight heparin therapy and other oral anticoagulants that target factor XA. The APTT test is insensitive to low molecular weight heparin, so the anti-XA assay provides more accurate monitoring. Reptilase is a snake venom enzyme. This test is similar to the thrombin time, but unlike thrombin time, it is not inhibited by heparin. That makes it especially useful for patients who are receiving heparin therapy. The reference range is 18 to 22 seconds. In fibrinolysis testing, fibrin and fibrinogen degradation products, also called FDPS or FSPS, can be detected. One method uses latex beads coated with anti-fibrinogen. This was historically used as a positive screen in disseminated intravascular coagulation. The latex D-dimer test uses a monoclonal antibody to the cross-linked D fragment. It is positive in conditions such as disseminated intravascular coagulation, deep vein thrombosis, and pulmonary embolism. Quantitative D-dimer testing is especially valuable for its negative predictive value, allowing clinicians to rule out thrombotic events. Intraoperative point-of-care tests are used to support highly invasive and high-risk surgeries. Impedance aggregometry. This is a whole blood method of platelet aggregation. It measures electrical impedance changes as platelets stick to electrodes. Thromboelastometry. This test measures the timing and elastic properties of clot formation throughout the entire clotting process. Different reagents and agonists can be used to test various hemostatic pathways. The bottom line? Factor assays and specialized tests provide detailed evaluation of coagulation, fibrinolysis, and platelet function. They are critical in diagnosing bleeding disorders, monitoring anticoagulant therapy, and guiding surgical management.